Good morning, afternoon, or evening to everybody, depending upon where you're watching us from or when you're picking up this broadcast. My name is John Moore. I serve as the co-chair of the DC hub of BOLDforce, one of 12 employee resource groups here at Salesforce. The BOLD in BOLDforce is an acronym, stands for the Black Organization for Leadership and Development at Salesforce. It's my pleasure to welcome you to today's broadcast, the COVID Town Hall, Restoring Trust in the Health System. Today, we're focusing on wellness, and unfortunately, there are very few issues that are as topical and relevant right now as COVID-19. So, as we all know, COVID continues to disproportionately impact our communities because of systemic racism and vast disparities when it comes to determinants of health like economic mobility, education, transportation, housing, and the list goes on. But now that we seem to be entering the next phase of the pandemic with vaccines being distributed, we're faced with some other equity issues around healthcare accessibility and the topic that catalyzed today's conversation, which is trust. And so, what we want to address today, which is really key to this conversation, is the fact that there is a trust gap that exists between the Black community and our public and private health institutions. And of course, those are real and relevant feelings that's rooted in a really troubled history between this nation's Black population and our health institutions. This trust not only shapes our attitudes toward the new vaccines, but it also has long played a role in our willingness to engage in a system that we feel has historically wronged us in so many ways. So where does that leave us today? Today, we want to have a conversation and achieve three things primarily. We've got this amazing collection of thought leaders, but one, we want to get smart, right? We want to get real and get smart. So let's talk frankly, but let's use data to inform that conversation. We're going to get some clear insight from our panelists on the impacts of the pandemic, both physical and mental, near term, long term, and then address head on what's been done to ensure to date that these vaccines and other health solutions are accessible to, and most importantly, safe for our communities. Number two, we want to get involved. So, how can we as individuals be advocates of equality? How can we identify some of those organizations that are on the front lines of fighting for equity for healthcare in Black and Brown communities specifically? And then lastly, get resources. We don't want to just come together and talk about issues without offering some sort of solutions. We want to walk away from this empowered, right? So what can enterprises like Salesforce and other businesses like us, other business leaders in our space be doing to contribute to this conversation, to contribute to the equitable distribution of vaccines, to promote culturally sensitive education campaigns in minority communities? But before we get started, because this is going to be externally facing, I have to share this statement with you. This is just from our legal team. This is what we call our safe harbor statement or a forward-looking statement. You probably don't have to worry much about any forward-looking statements being made in today's conversation, but in case you do make some sort of purchasing decisions, please make those decisions based upon publicly available information that is available today. And I'm going to introduce our moderator and our panel. So the moderator for today is the fabulous co-chair of BOLDforce DC, my colleague, Jasmine Waring, who serves as an account executive here at Salesforce. Joining her today on the panel will be Mr. Roderick Brumby, who is a health and human services executive on the global public sector digital transformation team here at Salesforce. A mouthful. I try to make sure I got it all out right. Rod, let me know if I got it wrong.
You got it right.
I got it right. Great.
Oh, yeah.
And we also have Dr. Zandretta Timms Cook, who is in practice as an infectious disease specialist at Wellstar Atlanta Medical Center and brings to us a wealth of experience and insight on the front lines of fighting COVID in our communities. We have Dr. Todd Ellis, who is a partner at KPMG. He's a principal for the Health and Government Solutions division there at KPMG and also hails from the Atlanta office. And finally, we have our friend Dr. Kamal Johnson, who is an associate professor at the Chicago School of Professional Psychology. So I am extremely excited about the conversation. Without further ado, I will turn the floor over to Jasmine. Jasmine, the floor is yours.
Thank you so much, John. And thank you to all of our panelists. Glad you guys could be here today. It's a really important topic. And just know that the questions today, all questions are open to all the panelists. They've been crafted and categorized to speak to individuals. But again, any of you all are very welcome to respond to any of the questions. So shall we begin?
Sounds good.
Let's do it.
Right.
Well, first, start with you, Dr. Timms Cook. Initially, it was thought that the Black population wasn't greatly impacted by COVID as much as others. But can you speak to the cultural issues and chronic illness and why Black people may be impacted at a higher rate by COVID?
Absolutely. First of all, thank you for the invitation and for being with each of you today. So this is a very loaded question. And it's one I think that those of us who are directly involved in healthcare on a day-to-day basis find as a challenge, but also as a calling to serve the people of our community. So I think that it's a multi-pronged challenge. First and foremost, we know what the access issues are. And some of those have been mentioned already at the top of this meeting today. But we have certain social determinants of health. Some people refer to them as fundamental causes of disease. So those are things like income and what that gives a person access to in terms of medical care, specialist care, your cultural things that you may have limited access to based upon your neighborhood, your venue. You can only eat what you have access to. You can only walk and have recreation in neighborhoods that are safe. So we know that those things play a part. But I think that we can't deny the legacy of cultural mistrust that goes back to things that we all know and hear about, things like Tuskegee and the Tuskegee syphilis study. And what I try to impose on patients when we're in one-on-one encounters is that legacy is one of lack of access. It's not that things were necessarily purposefully done to us, but they were limited access issues, which we now have a different situation where we do have access to them, but we have to first overcome that mistrust. And so I think that can play sometimes the biggest role. I just finished my last patient, actually. I'll make this brief anecdote about it. He is a young man, beautiful mind, who's living with HIV. He's 28 years old, and there is no reason why a 28-year-old should have any complications of HIV. But he shared with me that this is his first day in Atlanta, that he's driven from another city. He's just gotten here with everything he owns in his car. So I had to first give him a sample bottle of HIV medicines that I have. Otherwise, he doesn't have a job. He doesn't have access to any other care at the time. And he also shared with me that he's been diagnosed for about a decade and he's been taking herbals. And I asked him, how did that work? How did you happen to, choose that type of care for yourself, knowing everything that we know about HIV, and how has that worked? So he said, the person assessed him and his history, and so he has been relying on that. So what I've chosen to do with him is to take this one step at a time, to first establish a rapport that allows him to trust me and any information I may share, but then to have a longitudinal conversation with him that hopefully coaxes him to have more trust in the healthcare system.
Wow, thank you, Dr. Timms Cook. And there was a lot there, that you shared as far as the cultural history that Black and Brown communities are dealing with, coupled with the access issues. Thank you for sharing. I want to dig deeper and actually pass this to Dr. Johnson. Dr. Timms Cook spoke about her patient. He had a beautiful mind. He came to the Atlanta area with HIV. Can you speak to that? Because with healthcare, Dr. Timms Cook is looking holistically at her patient, but also from the mental perspective, Dr. Johnson, Can you speak to the how the physical and mental health are intertwined?
Yeah, that's a great question. And certainly Dr. Tim's Cook example illustrates how there's an intersection between mind, body, and spirit, if you will, coming from or looking at health from a biopsychosocial perspective, in that there are biological components that contributes to disease and illness. There's psychological factors that contribute potentially as well. Say, for example, once a person acquires a medical condition, how is their coping? What are their levels of stress? How motivated are they to adhere to the medical regimen and other things that are required as a part of their treatment, their motivation to engage in those things? And then the social component involves their relationships with others, their relationships with the medical team and staff that is providing care, their relationships with their loved ones, family members, other important persons in their lives that can either support their treatment and well-being, or in some cases may pose a potential barrier and hindrance to that. So it's important to be aware of all those factors as they contribute to devising a very positive and advantageous approach to treatment, and to incorporate the patient, his or herself, in playing an extremely pivotal role in terms of prioritizing the treatment goals and outcomes, and having a positive alliance between the medical team and staff. And a good portion of that is related to trust that Dr. Tim's Cook emphasized for us, so that the patient feels that you're truly invested in their recovery.
Thank you, Dr. Johnson. And I can see how, and I'm sure some of our guests can see how, there's so much more to this equation. We're speaking of mind, body, spirit, trust in their healthcare provider, trust in the larger system. And speaking of trust in the system, you spoke about the medical team and the staff. I want to go to Rod next. Rod Brimby, taking a step beyond the medical team and the staff. Having served 2 terms as the commissioner of the Connecticut Department of Social Services, Rod, can you share with us some of the roadblocks you saw as it relates to quality healthcare and social services delivery to the Black community when you entered that role?
Happy to do so, Jasmine. And also, I'm really delighted to have the opportunity to join this panel. So the fundamental roadblock that our administration faced was, to put it bluntly, misplaced emphasis. Access to care, as Dr. Tim's Cook mentioned, was thought to be sufficient, necessary, but insufficient in my way of thinking. Our Medicaid program back in 2011 was delivered through a contractual relationship with 3 managed care organizations. The state's primary objective was efficiency. There was general concern that Medicaid expansion, and this was pre-ACA, would destroy the state budget. Does that sound familiar? So in 2011, the Medicaid program's contracts with managed care organizations, there were 3 of them, capped the state's annual Medicaid expenditures by transferring risk to the MCOs. If expenditures remained below the allocation that the state gave to the MCOs, then they were allowed to keep the difference. If the expenses exceeded the allocation, then the MCOs assumed risk for the difference. And they could and often did request additional funding for the subsequent program year to accommodate program growth or increase costs. So ironically, there was little incentive to hold down costs. But at the heart of this transactional system was a lack of emphasis on equity. We had poor data about who was being served and whether they were getting any better, let alone whether members were experiencing improved well-being. The governor, upon assuming office, realized that the $3 billion budget deficit that he inherited would not allow us to implement a single-payer state health plan, as was promised and expected by a lot of people. So we did the next best thing. We implemented a single-payer Medicaid program with federal and state resources. We deconstructed the relationship with the MCOs and elevated equity by assuming full risk as a self-insured single-payer program. Radically, we transitioned away from the MCOs and partnered with a single administrative service organization to operate some of the administrative components of our program, but with equity top of mind. Our Medicaid program established provider rates. We paid providers directly. We assured that providers were proximate to the communities being served. And we recruited and expanded the pool of providers to include more people of color and culturally competent healthcare professionals. Now, a key service innovation that I want to mention was the use of technology to perform risk stratification on the entire Medicaid membership. We were able to then develop actionable program costs and quality data. The ongoing analysis allowed us to identify and array Medicaid program participants with the greatest risk of increasing healthcare challenges with early interventions so that we could disrupt the cost trend. We created an intensive care management program with the ASO. We deployed nurses as care managers to ensure that members most at risk got the attention they needed to improve well-being, whether that was access to specialists, transportation to appointments, or other social services to address key challenges of daily living. So by focusing first on equity over efficiency and putting the health of our members first, we were able to reduce the PMPM, or per member per month costs, by a greater rate than any other Medicaid, Medicare, or private program in the nation between 2012 and 2017. And this is according to a 2017 article that was published in Health Affairs. Overall, we saved billions by centering equity in serving Medicaid members.
Wow. Rod, I can't necessarily speak for everyone, but I don't think it's very common for organizations to recognize the impact that equity over efficiency can have on not only patient safety and quality of life and health, but also on the budget. You said that you all were able to save billions.
Billions with a B.
Wow. What were some of the challenges you faced in that role, in helping to make that shift as far as the people, to make that shift from focusing on efficiency to leading with equity to bring about efficiency and save those billions of dollars?
At its core, it's a change management process. It's helping people to understand why being equal, treating everyone the same is insufficient. Equity means we have to give the right attention to the right people at the right time for improved outcomes. We don't all start this race at the same place, but if we want to finish, and we want to finish well, we may have to provide more of an opportunity or more support or more capability in order that we all succeed.
Wow. Thank you for that. Thank you for sharing that. Let's pivot now to Dr. Ellis. Dr. Ellis, there's an HHS-funded initiative to develop and implement targeted strategies to address the needs of traditionally underrepresented populations, which have been disproportionately impacted by the COVID-19 virus. What role is KPMG playing in supporting that program?
Thank you. And again, first and foremost, thanks for having me today. And I've actually learned something already from the three panelists. So this has been more informational to me. So thank you for that. But it's interesting. It's a first of its kind program that is being sponsored by HHS through Morehouse School of Medicine. And we're teaming with Salesforce in building this platform. And actually, the platform is actually live. It's called the National COVID Resiliency Network. It is live. You can actually go out there right now. But one of the key aspects of this national platform, it is focused in on populations who are underrepresented: African Americans, Latinx, Alaskan Americans, Native Americans, Asian Pacific Islanders, to name a few. And the key is access. You keep hearing certain terms from the panelists. Access. That's so important because for a long time, these populations, and even today, it's shameful that, in my opinion, that we're having these type of discussions in the year 2021, because these are the same discussions that have been had for 20 to 30 years, even longer than that. And it's still a struggle. We're still dealing with these issues. And that's why I say it's a shame, not on us, but on America, on United States. We should not be having these discussions. We shouldn't, but we are. My biggest fear is this, and I'll get back to the platform. I think we understand how we got here today. Over the past 12 to 16 months, there's been certain incidents that have happened, right? But what we can't afford to do is sweep this under the rug after COVID is gone, because there's going to be another crisis. There's always crises. My biggest fear is this: after COVID is over, we're going to enter into another crisis. We know a lot of these populations have put off seeing or getting preventative care. They've put off going to the doctors for diabetes and hypertension out of the fear of going to a hospital for COVID. But guess what our next crisis is going to be? When COVID is over, you're going to have a segment of the population that has not received health care. That's going to be our next crisis, and what happens after that. But getting back to the platform, I got off on a tangent. I'm passionate about this. I'm sorry.
No problem.
Yeah, I'm sorry. I get very passionate about this. But what I love about the platform is it's a national platform, and it's about the dissemination of COVID-related information to these populations through focused efforts with community-based organizations at a national level that are tied to these communities. Let's be honest, there's not a CVS and Walgreens in some of these communities, right? And sometimes they opt not to put a CVS and Walgreens in these communities. We got to be real about this, okay? Let's be real about it. A lot of these populations, they deal with the churches, local public health agencies. So we've partnered not only with Salesforce, but we've partnered with CBOs, over 50 CBOs that really understand what's going on in these communities. Because I'm gonna say one thing about technology. Mm-hmm. Technology is not gonna solve this. It's a piece of it, right?
Right.
We can't expect that we throw technology at this in these populations where a lot of these populations don't have internet access. Let's be honest.
Yeah.
They don't have laptops. They don't have the fancy cell phones. So while technology is important, I think that's a good step. Let's not be ignorant to the fact that technology is not going to solve this for these populations. It's going to help, but it's not going to solve the entire issue. Mm-hmm. Right? And we gotta be very cognizant of that, because I think we live in a society now where Apple and Microsoft, they develop these technologies for people who can afford it. I mean, come on, let's be honest. They develop these technologies probably for 80% of the population who can afford to benefit from the technology. But we can't forget about those who can't afford the technology. And that's why I'm saying technology is a piece, but it's not going to solve the whole issue. So again, I'm going to apologize. I'm passionate about this, but I'm going to be quiet because I just go on a soapbox and I don't want to do that. And I want to be respectful, but thank you.
You don't need to apologize. No.
Not at all. Not at all. Not at all. And exactly. I mean, we recognize it's not easy. It's not easy. It's not a one size fits all. And technology is just a part of it. A part of it. Any of the other panelists want to chime in and share with what we're dealing with as far as access being one thing, but also trust in the system and the history that we're dealing with. This question was initially directed to Dr. Timms Cook, but for anybody else who wants to share, how do we best, with the history that we're dealing with issues with access, how would you suggest we hold ourselves accountable now to respond to the vaccination and recovery process?
Well, I'm gonna make one point.
Sure.
So, and this is for the panelists, because if you look at our hesitancy with the vaccines, it's warranted, and I understand why. I have these conversations every day with people in my family, right?
Yeah.
You know, don't get the vaccine. We don't know what's in it, Todd. I just don't want to take it because I'm fearful of what's in it and what's going to happen to the African American race, right?
Right.
But also, I think we as African Americans in these populations who are underserved, excuse me, we're going to be put in a very difficult situation, in my opinion. We understand that a lot of the African American community, as well as these underrepresented populations, they are the frontline workers. I've been having discussions with some states and some businesses saying, well, guess what? We're going to mandate. If you want to work here, we're going to mandate that you have to take the vaccine. And we know a lot of these populations, they need the money. They have to work.
Mm-hmm.
Right.
So they're almost being forced in a corner to say, you know what? I'm worried about the vaccine, but I need to work. So now you're forcing me to take the vaccine for the livelihood of my family. So when we start talking about mental health, mental well-being, think about the pressure that puts on a person of color.
Yeah.
I'm a frontline worker. I don't have the luxury of having 6 months to a year of salary to get through this. Now you are forcing me to take this vaccine because I got to feed my family. I got to keep a roof over my head. The mental anguish and the mental stress associated with that, I can't even imagine that.
Mm-hmm. Mm-hmm.
But that's a piece of it.
It is. Dr. Johnson, do you want to chime in on that?
No, it's absolutely true. I mean, it's an extremely difficult situation in terms of folks making informed decisions that they feel are in the best interest of their own health, as well as others that they care about. And it often involves the degree upon which folks feel a sense of power and control and autonomy, you know, in their lives, and are able to act upon that as well. And so being faced in very, very difficult situations and dilemmas. And again, going back to issues related to trust in terms of the vaccine, in terms of its being a valid and reliable and safe instrument to protect folks. I was in a conversation with a brother who worked at NIH. He's been involved in some of the research in various vaccines, and he was also very sensitive to this issue, and really emphasized the importance of us getting information that is accurate and reliable, so that we can make the best decisions for ourselves given the circumstances that we're facing.
Thank you. Thank you. And Dr. Timms Cook, from your perspective, you're an infectious disease doctor, but also an African-American woman with a family. What are the conversations that you're having with your patients, or potentially with family members who may or may not be convinced of the safety of the vaccine?
Right. So, you know, first I want to answer the initial question that you asked about how do we hold ourselves accountable. I think we do so in the one way, in the format that we're doing right now.
Mm-hmm.
I think the Black community does an excellent job, outstanding job, providing information, translating information, disseminating information to our community. And I know for me, and I'm sure several other panelists probably are the same, where there are countless venues and forums like this one today where we're speaking on this topic, and we're at least allowing people to make informed decisions about the vaccine. But, you know, I try to stay rooted in the science, but sympathetic to the history and the fears that people have. And we try every avenue to make the information palatable and to give people access to it. So for me, the conversations have been providing the science, and then sometimes people just flat ask, like, just what do you think? And then we have a very real conversation about it. And I tell them something like, you know, I am seeing and have seen the deaths. I'm right at the bedside when, you know, we're calling in the family, and we've seen this far too many times happen to families who look like us. So you're having to make a hard decision. You're choosing which evil you're willing to accept. Is it the fears from the vaccine, or is it the fear of death? And we have to make that real decision. The other thing I will say is that we have moved our office in the neighborhood. So we're not over in Buckhead. Patients don't have to take a bus, a train, another bus to get to us. There's a bus stop right in front, and we have a neighborhood office. This office where I sit was once a home that has been renovated. It's now an office. The parking lot outside, we've done COVID testing. And so we've invested in a refrigerator so that we can do everything appropriate for the vaccine. So when patients are ready to get the vaccine, when they've gotten enough information that allows them to make that decision, we're here. And up and until they get to that point, we're going to continue providing that information in whatever, format that is needed to make that decision. And so that's how I am doing it. That's how colleagues of mine are doing it, just little bits and pieces at a time. Prochaska's stages of change, I always keep that in my head, that you don't throw a habit or a thought out of the window, but you coax it down stairs one step at a time. So perhaps that first conversation is I'm just gonna ask you if you're considering it, and that's all I want to know. Are you thinking you might get the vaccine? What I've heard a lot is I mean, that's the answer. Why? Can you tell me why? Like, what are your thoughts? What have you heard? And let's just talk about that. And then that's it. That's all we're going to do today. When you come back for your next visit, we'll talk about it a little bit more. And, perhaps, there's something else that has struck you enough, to have a different conversation. But that's what I would say.
Thank you. Thank you for sharing that. And what resonated is there's some overlap in the conversations that you have as their physician and the conversations that many of us can have as peers, as family members. When John kicked this event off, he said we want to get real, get involved, and get resources. And so that part about get involved, that part that you spoke about of being real, about you're seeing it on the front end, you're seeing the deaths up close, and it's looking at that versus the possibility of what if, the small seed of doubt of what if later. And it's a tough place that a lot of people are in, but that's one thing that's resonating. That's something that's a conversation topic or talking points that can be had with anybody. That's something that we can all do as far as holding each other accountable to those, just going deeper in the conversations, kind of like what we're doing today. So thank you for sharing that.
That's right.
So for you, coming back to the public side of things, as both public and private organizations are looking to manage vaccine programs, market-leading solutions like Salesforce's work.com for vaccines, Vaccine Cloud offer powerful capabilities to help agencies and businesses accelerate their vaccine management and distribution programs. Now that vaccines are available, aside from the conversations that we're having with our peers or that the doctors are having with patients, what should agencies be doing to prepare to respond at scale?
That's another great question, Jasmine. I'm going to put on my public health hat here for a second. I also had the privilege of serving 2 terms as the Secretary of the Kansas Department of Health and Environment. So from that perspective, and this is going to sound a lot like the commissioner hat too, I think that as vaccines become increasingly available, organizations need to, guess what? Center equity in their planning as they execute the nation's largest and most complex vaccination effort ever. So vaccine hesitance, and we've talked a little bit about this earlier, but I think it can be understood as a legitimate and reasonable concern for communities of color, given the historic and current experiences of indifference at best or systemic racism at worst by public and private healthcare systems. So to be successful, we'll need to be intentional about who's getting vaccinated and how quickly. Now, Vaccine Cloud is loaded with powerful end-to-end capabilities that help organizations accelerate this work. I'm going to mention just several capabilities in particular. But key is probably the command center. It's a way of assessing and monitoring in real time the vaccination penetration rates for various communities and geographies, in addition to the inventory and allocation of vaccines, supplies, and personnel. This single source of truth can inform modifications in operational plans to address those deficiencies in vaccination coverage. So again, dashboard, it's that command center. So then the enrollment and scheduling capability, that enable residents to reserve their virtual place in line or access a virtual waiting room until the vaccine is available and the appointment is scheduled. They don't have to sleep out overnight to get in line. They don't have to worry about missing an opportunity to make a phone call. You can schedule these opportunities in waves so that they can call into a center or use technology to get into a website or a portal in order to get and reserve their place in line. Organizations can actually configure the platform using this capability to capture race, ethnicity, and language data. And that helps to increase the accuracy of the information to guide their efforts. Successfully vaccinating communities of color will help us all out. And sometimes people think, well, that's just for that community, but no, in this, we are a collective. And I'm going to share a little bit why that's the real deal. In most customer meetings that I've had the privilege of participating in, I share a vaccination objective, how long it might take to achieve community immunity. For example, for DC to achieve community immunity, the seating capacity of FedEx Field, that's some 82,000 seats, will need to be vaccinated 11 times. Okay, fill up FedEx Field, vaccinate everybody in it, and do that 11 times, and then you might get to community immunity. At the current rate of about 2,500 vaccinations per day, Bloomberg establishes and estimates that it'll take about 12 months for the district to achieve community immunity. That's too long. But now, here's the complication. How much longer would it take to achieve community immunity if 100,000, and this is roughly a third of DC's Black population, opts out or is late to being vaccinated? That means we can't go back to a semblance of the normalcy that we had. That's further delayed. So we can do better, but we must be intentional about appropriately placing our collective emphasis on equity. So that's just my thought about how we might go about this.
Rod, I got a question for you. And again, this goes back to equity, right? So we know equity is important, not only for COVID, but for anything related to health. It's so important because I like to say if the underrepresented is healthy, we're all healthy. We're all tied as one, like you said. We are. But I was looking 2 weeks ago at some of the stats in New York. You know, New York City, 60% of the vaccines that have been administered have been to Caucasians. 10%, no, it's 5. It's actually, it's 5 to 10%, somewhere in there is Hispanics and African Americans. So that just goes to show you, we talk about equity. I think people want to do the right thing. But if you look at the New York City stats, the numbers are just, the gap is just so wide. You know, how do we get to, not only from COVID, maybe this is the first stepping stone, but I think, how do we learn from this experience to carry on the theme of equity? Because again, I'm so fearful that after COVID is, you know, we get the herd immunity and we get past this, we're going to go back to what we were before COVID, where health equity was already there, inequity was already there, but there really wasn't a spotlight on it. You know, let's be honest, there really wasn't a spotlight on it like it is now. How do we prevent ourselves from going back to that after COVID is over?
So Todd, I learned early on, and I was taught this, drill this over and over again, is that what matters gets measured.
I agree.
We are not even tracking the race and ethnic
That's a great.
and language that's used by people that are being vaccinated. The CDC's first report, the first month of vaccinations, 12.9 million people. Of that 12.9 million people, 48% of them did not report, it was not captured, let's put it that way. It was not captured what their race, ethnicity, or language was.
Yeah.
So how do we know how well we're doing?
Yeah.
We got to be intentional. CDC yesterday reported that 2 months in, we've got 34.7 million people with one dose. That's, less than 10% of the population.
Right.
And 11.2 million fully vaccinated. That's just over 3.5% of the US population. We've got a long way to go. But further than that, we need to know how we're going and who's going down that road with us. And I agree wholeheartedly, Todd. This has to persist beyond COVID. We can't find ourselves back here again.
And I think it's on us, everybody who's listening in, the panelists, we got to keep that flame going. I mean, we can't let it get swept under the rug, because it would be heartbreaking to know, again, we're having this same discussion next year about health equity, and it's another crisis after COVID.
Yeah. Dr. Ellis, what else would you say as far as what do you anticipate to be the most effective educational tools to collectively do that, empower communities to combat this disease, not just this one, but in the future, as you're speaking on equity?
You know what, Jasmine? If I had that answer, I'll probably be on my own private island, living the life, never worrying about money ever again. I have to keep it light. I have to keep it real. Okay, that's the real answer. No, but seriously, there's no one perfect. There's never going to be one perfect answer to that question. There's never going to be that. Like I said, we have technology, and technology is great. I love my cell phone. I remember, I'm dating myself. God, I remember before the cell phone, but I love my cell phone. I'm tied to it. But not everybody has that. Not everybody's going to adopt technology. Not everybody wants to use technology. But then again, the community-based organizations, those are so important, the outreach, because the churches, we do have a lot of faith in our churches, right? We do. So I wish I could answer that. I think it's going to be a combination of technology, but then again, we got to make sure everybody has internet access, they have the right technology tools, and that they use them, right? Because remember, social determinants of health plays into all of this. Right. Education, right? Education gets you a job, your job, it's been proven. If you have education and you have a job and you have a good income, your health is better because you have insurance. There's just a lot of different things that play into this, Jasmine. Yeah. I wish I had the answer, but I don't. But, as we become more educated, hopefully we can all collect our thoughts and figure out what is that critical path to health equity for these populations.
Well, and that's the start, different professionals and different people from the community coming together with different backgrounds and different experiences and knowledge, bringing it together, having that progress. I appreciate you being real about it and sharing that you don't necessarily have all the answers, but we're taking the steps. And I do see, sorry, go ahead.
I think we are. Go ahead, Dr. Johnson, please.
I just want to say that point is extremely important. I mean, just looking at the panel, and then if we could actually see those that were participating as well, just the diversity that exists in our own communities and the strengths that are there in terms of our levels of discipline, whether it be in medicine, whether it be in public health, whether it be in the business sector, and to be able to pull those resources in a very directed way to solve the problems that we're facing, in the community. It certainly it's been encouraging to see aspects of that in terms of COVID, in terms of vaccines, in terms of the roles that some churches are beginning to play in terms of increasing access to folks within the community that may not feel comfortable, even have the ability to get online and to schedule and those kinds of things, but feel comfortable going to the church where their pastor that they know is getting the vaccine, and the dean and the deacon and other persons of note and respect for in that community. And so we need to see more of those kinds of things. The roles of HBCUs and other Black organizations certainly play a key role, and elected officials.
I'm gonna give you guys a story, and it's very painful to me. In my old neighborhood, I had a great neighbor. He was married, had kids. He was a Marine. He retired as a Marine. And he passed away of COVID 3 weeks ago. And let me explain why he passed away of COVID. He's a God-fearing church man, always been in the church. He opted not to go to the hospital out of fear of going to the hospital. So he took it upon himself to say, I'm gonna get through this and battle this through being at home and I'm in my bed. I'm just gonna battle it through with my wife. He was having trouble breathing, and he just refused to go to the hospital. And he passed away in his home, just out of fear and angst of going to the hospital and being on a respirator. He didn't even want to do that. He thought he could beat this going through prayer, and prayer is strong. I believe in God. I get it. I get it. But that's part of our community too. We're very religious people. But he felt like he could get through it through prayer versus the advice of his physician. I'm not saying that he was wrong. I'm not saying that. But I think it's upon us to help educate our people on, like Dr. Tim Cook said, science, right? That's so important. But I also understand the strength of religion in our community. But it pains me and it hurts me that he stayed in his home and refused to go to the hospital and prayed on it. And that's fine. But he passed away, and now, his wife, Debbie, she doesn't have a husband. His children doesn't have a father. So what I'm saying is this: religion is important. And I see the role of religion in helping with health equity and being a resource for our population. But then again, we can't ignore the science, what works. And sometimes it does this. Sometimes it does this. So what I'm saying is we all got to take part in helping educate the African-American community or any community about doing what's right and letting them know what's safe and giving them a perspective. They may not take it, but just let's not sit idle and watch that happen, because I lost a dear friend. I lost a past neighbor to COVID, and it was painful to watch that and hear him that he passed away like he did.
And I'm sorry to hear that. And Dr. Ellis, I'm sorry to hear that it happened so close to you.
Yeah.
And the fact that it's a story that many people can probably relate to.
Yeah.
So it's meeting people where they are. You speak to meeting them at the church. Many of us are religious, but also whether that be social media or social communication, but it's definitely, I can definitely see it taking many layers approach to be able to reach people, to be able to dig deep, especially with the troubled history that we have with the healthcare system. And so thank you for sharing that. Did anybody, I see some questions coming in from people who are participating. So I just wanted to see if there was any of the panelists that had any other suggestions as far as resources to help get the information there.
I wanted to say something. I think two things, in my opinion, could change the way we as a community view science, view studies and research. I think historically research in the African-American community have not played well together, either because we were utilized in ways that were morally corrupt, or at the end of research, there's something that is I don't know, we're not seen in the best light. The data are not in our favor, or they're not showing us at the greatest advantage. So I think having education just around the whole concept of research and how that can be used in ways that really benefit the things that matter to us. I think that point was brought up previously, that you only measure what matters. So I think utilizing research for us in areas and in avenues that matter to us, and having a chance to see the outcomes of research put us in a more favorable light. You know, I'm thinking the majority of the research I've seen, it tends to just give support and credence to things that just always make us look like we're not doing it right enough or great enough. So that would be the first point I want to make. And then I think prevention goes a long way, and having a buy-in on the side of prevention. I completely get it that when your life and your plate is already full and you already have a lot of responsibilities, it's hard to utilize any extra energy towards preventing something that hasn't even happened yet. You got to deal with what is real and what's happening today. But the flip side of that is that 1 ounce of prevention is worth a pound of cure, literally. And so having a buy-in in that, whether it be COVID and the vaccine that's now available, or HIV and their preventive strategies for even HIV prevention, diabetes management. So I think having a buy-in, having more education around those 2 pillars could allow us to have more confidence and more faith in the science and research outcomes that we see.
Yeah, I wholeheartedly agree of the importance of looking at this beyond, as important as COVID is right now in the pandemic that we're facing. But clearly all of the other medical health issues facing our community did not evaporate once COVID hit, in terms of issues of comorbidity, the issues of cancer, cardiovascular disease, stroke. These are issues, diabetes, still impacting our community, and as well as issues related to mental health that compounds these issues, including substance use and abuse. So these are important things for us to prioritize and to utilize science in a positive, proactive way to see that, in fact, we can certainly make changes, not only as they relate to COVID and infectious diseases, but also significant chronic diseases and the major impact that they're having in our communities. These are things that we can absolutely change and control for better outcomes.
Yeah. You know, Dr. Johnson, you know, I always think about it, and I want people to think about this as we leave this meeting, is I think about growing up, and I grew up in the South, in South Carolina, and it's hard enough being human, right? Just being a human. It's hard enough for all of us, just getting up every day and being human. Now just think about that, being an African-American or underrepresented a segment of the population, all of the stuff you have to deal with.
Yeah.
And then just being human, right? Then just being human.
Right.
We just can't ignore mental health. It's so important, because some people, they don't have good coping skills to deal with what it's like to be an African-American and deal with gentrification, segregation, all of the stuff that we've dealt with, all of the history. And then just to, again, to try to live as a person. So what I'm saying is the mental well-being is so important in all of this. And we got to find ways as African-Americans and other diverse populations to not to have that stigma around going to get counseling. I mean, there's a stigma in our community. Why are you going to get counseling? Something wrong with you? But it's just one of those things where it may not be related to this topic, but we do need to focus in more on mental well-being and how to cope with a lot of the pressures that we get inherently just for being an African-American and not just human.
I'm glad you mentioned that. And Dr. Johnson, that was a question that we had for you and just have run out of time. But I'm going to let you wrap it up with there, but invite you right now for another talk, because that, Dr. Ellis, it's a full discussion, you know, and that's the tip of the iceberg thing, that we move so fast and are so busy doing what we do that we may not take the time to really assess the lines between stress and mental health and the impact of, or being in that situation of being on the front line, being a frontline worker or any other type of worker, and needing your income for survival and what that means and the impact of the pandemic. And so I definitely am inviting you now, Dr. Johnson, to come back.
Oh, it would be my pleasure. Again, it was an honor and a privilege to be a part of this panel. So I'm certainly in extended gratitude to have an opportunity to participate in future events as well.
Thank you. And thank you to all of our panelists. You all have been amazing today. We've gotten so many nuggets. Measure what matters. That's a heavy hitting takeaway, to be able to see the impact, you know, and the fact that that leading with equity can actually lead to better outcomes, can save billions of dollars. Just that point alone really can open some eyes, because we got to face it, equity is not important to everybody.
Right.
But then when it's tied into saving billions of dollars, now eyes are starting to open. And so thank you all for being real. I mean, the goal of this talk was to get real. We've done that. Get involved, even if that's just having the conversations, having the difficult conversations, and then getting resources. So thank you all for being that and providing that. And so if there are, we're right at the 1 o'clock time slot, and I want to be respectful of everyone's time. But if there's any burning questions that we have time for, is there any burning question that we didn't get answered, or are we able to cut it now?
If no question, I've got one burning
I'm sorry,
statement.
Rod. I was just going through the questions that were submitted by the folks who were on the line, and there are a multitude of them. I could share a few, but Rod, if you have closing thoughts, or if anybody has closing thoughts, I welcome that.
I have just one statement to make, and that is that we're in the race of our lifetime. I mean, this race to community immunity is no joke. Our ability to vaccinate people as quickly and as equitably as possible is up against this virus's ability to mutate and spread even faster, with even more devastating consequences. But we can only run this race as fast as we can develop trust. So the key to our success in this race is going to be trust.
Yes. Wow. Well said.
Hey, Jasmine, that was a drop the mic moment.
It really was.
Very worthy one.
It really was a drop the mic. It was drop the mic moment. I think we should drop the mic at that point. John has burning questions from anyone.
No, what was shared was actually an observation, and I think it's valuable to share this observation from Scott Campbell. He's one of our account executives here in public sector, and he says, thank you to our panelists for exploring this important issue. And I just wanted to share this because for anybody that might be listening and is curious about maybe some existing programs that are out there, some of the good work that is being done from organizations that are cognizant of the challenges that are being faced by underrepresented and minority communities, this might be a good model for you to look toward for inspiration. So in addition to women and people of color, you know, our veteran community is also at high risk, and it gets even worse when you start to look at intersectional statistics with female veterans and veterans of color. But he shares that Veterans Affairs has a great concept led by Dr. Tracy Godet called Whole Health, that incorporates the patient and allows them to set their personal wellness goals. And he suggests that perhaps that's a thread to pull upon for engaging in restoring trust and delivering care that is proactive, personalized, and patient-centered. And so if anybody is interested in learning more about that, you can take a look at va.gov/whole health, WHOLE health.
Awesome. Thank you so much for sharing. And with that, we're going to end our segment. just a couple minutes over, but thank you all so much for being a part of this panel. We really do appreciate your insights, your candor, and being real and bringing resources as well.